I'm sorry for this delay. It seems to be happening everywhere at this meeting. So I'm basically going to talk about pitfalls in perimetry when you get confused as to whether this patient has glaucoma or not. We all know that you need to know Anderson's criteria to designate a patient's visual field defect as glaucomatous or non-glaucomatous. I won't go into the details. But when you are presented with a visual field test, you have to decide whether there is a field defect or not, and if it is glaucomatous. Is this defect glaucomatous? You can see that the glaucoma hemifield test is outside limits, and there are sufficient number of points, non-edge points, which satisfy the Anderson's criteria. But you have to correlate it with the optic disc, and you can see here that there is an inferior notch, there is peripapillary atrophy which corresponds with the inferior notch, and there's a nerve fiber layer defect as well. So this is a glaucoma defect. Is this a glaucoma defect? It's pretty bizarre. You have a dense defect inferiorly, and with just this test alone, can we say whether there is a defect, whether there is a glaucoma, whether it is some other problem? Again, correlated with the disc, you can see that this disc is a fairly large disc with the normal cup-disc ratio, the no obvious defect. So this patient had a language issue. She was a Bengali, and the test was explained in English by the perimetrist. So once a translator came and told the patient about how to perform the test, the results were much better. Is this defect glaucomatous? It's unusual to have such a dense defect in the periphery of the field. So this was found to be a lid artifact, and after taping the lid and then going ahead with repeating the test, you can see that the test result is much better. I think we all know what this is. This is a lens rim artifact, and once you correct with contact lenses or use full aperture lenses, then this defect disappears. What about this? This is unusual. You might at face value think that this is a nasal step, but a nasal step doesn't cross the horizontal meridian. So this is caused by a cylindrical lens rim artifact when you use frosted slides to correct the refractive error for the patient. So it's better to use a full aperture lens, and we published this in the Clinical and Experimental Optometry Journal. Now this is very unusual. You can see this is a tilted optic disc in a myopic patient with a very large area of peripapillary atrophy, but this is bizarre, doesn't correlate at all. And you can see that the refractive error here has been entered as +1. Once a correct prescription was in place, you can see that the report is much better with just an enlarged blind spot which correlates with the disc appearance. This again is a little bizarre, isn't it? It looks as if this patient has two blind spots. So what happened was that the perimetrist had entered the wrong eye. In the patient details, for left eye she had entered right eye, and this is why you had this fallacy. So once this was corrected, you have a much better result. Now this is a patient with a centrocecal scotoma. So what do you do in this situation? You can see that the patient has a lot of fixation errors, and the foveal threshold is pretty low. So the patient has a macular pathology. So you can use a large diamond in place and then get a better delineation of what the actual defect is. This again, what kind of a defect is this? Do we need to see this patient? Is it very advanced glaucoma? Both the perimetrist and the patient were fast asleep. So once they woke up and the thing was corrected, you can see that the result is much better. So that's something that you have to look out for. Now this is something that we often see. You have a defect which doesn't appear to be very advanced, but you have a central point which is very close to the fixation. So in this case, you have to repeat the test with a 10-2, which shows that the central points are much more affected in detail, and you may miss this if you just do a 24-2 test alone. So the latest Humphrey series, you have the two combined in the 24-2C, so that you have a tighter grid of test points tested in the central visual field. Is this defect glaucomatous? No, it's not, as it was described earlier, because this defect corresponds with the coloboma of the retina. Now this was a very bizarre defect. You can see that there's a superior notch with a nerve fiber layer defect. Here you see a tilted disc with an inferior notch with the nerve fiber layer defect, and this corresponds with the visual field also. So this patient, we did a daytime DAVT, and we thought nerve fiber layer defect is there, corresponding visual field defects are there, so it's better to treat the patient. But however, on going through the literature, we found that there is something called situs inversus of the optic disc, which presents like this. And this was very interesting. After this, we decided to discontinue the treatment and follow the patient closely. Over a period of 4 to 5 years, there has been no progression at all. So a false labeling here would have been disastrous for the patient. This was a patient who was seen elsewhere, and these were the baseline disc photographs taken, and the patient underwent visual field examination. And based on this, visual field treatment had been started. But you can see that this is a typical chloral leaf pattern, and when the visual field test was repeated, the patient has done much better. But there are patients who have prolonged learning curves, and if this continues over 4 or 5 fields, you have to switch over to progressive optic disc photographs or use imaging. And you can see that in this patient, there was a significant difference in the disc size, which accounted for the cup disc asymmetry. So don't get carried away by that. Is this defect glaucomatous? It's unusual to have a nasal defect which is not close to the horizontal meridian. So this was a 24-2 examination. When we repeated with 30-2, the defect was did not really correspond to a pattern that you see in glaucoma, and on imaging we found that it was a pie in the sky neurological defect. Now this is coming to progression. For lack of time, I have not gone into details. Sometimes we do an overview analysis, and you can see that this patient, while following up, the defect was increasing. Pattern deviation shows increased number of points which have been affected, but this suddenly disappeared. How did this happen? This patient had a posterior subcapsular cataract which was responsible for these defects, and once the cataract surgery was done, the defects magically disappeared. So in conclusion, a detailed history is important, detailed baseline examination, identify the risk factors for glaucoma, do a good correlation with the disc and fields, identify unusual features for both the disc and fields, make informed decisions in each individual based on current evidence, and don't hesitate to take a second opinion if there are unusual features. Thank you.
Thank you, Dr. Shantha, for nicely explaining that the visual field examination is complementary